Hi, and welcome back to Ready, Set, GYO, your on-the-go guide to learning gynecologic oncology. I'm Sydney.
And I'm Maya. This is a podcast for fellows by fellows. We are here to help you explore the diagnosis and treatment of gynecologic cancers, master the standards of care, and stay on top of new practice-changing publications.
Let's get ready to GYO! This is our first content episode for this podcast, and is our first episode in a 4-part series on uterine cancer. Today, we're going to be discussing the diagnosis, histologic subtypes, and staging of uterine cancer. Maya, what are our learning objectives for today?
Our objectives are to describe the epidemiology of uterine cancer in the United States, to identify the risk factors for development of uterine cancer, to characterize the ways to think about types of uterine cancer, identify prognostic indicators, to do a deep dive into the FIGO 2023 uterine cancer staging system, and to introduce next steps for management of newly diagnosed uterine cancer. So Sydney, what's going on with uterine cancer in the U.S.?
So uterine cancer is the most common gynecologic cancer in the United States, with over 66,000 new cases diagnosed and over 13,000 deaths in the year of 2023. In fact, this accounts for 3% of all patients born with uteri. They'll eventually develop uterine cancer. However, it is important to note that worldwide cervical cancer has the number 1 incidence of gynecologic cancers, with uterine cancer following as number 2.
Unlike other gynecologic cancers, both incidence and mortality from uterine cancer are rising. The increasing rate of mortality is thought to be related to an increased rate of advanced stage cancer, high-risk histologies such as serous carcinomas, and an increasing proportion of patients being diagnosed at an age greater than 65 years.
According to the SEER database, which stands for Surveillance, Epidemiology, and End Results Program, at time of diagnosis, 67% of cases are confined to the uterus, 19% are spread to regional lymph nodes, and 10% have distant metastases. 4% are unstaged.
In the United States, patients identifying as non-Hispanic Black have both the highest incidence of uterine cancer as well as the highest mortality, with nearly twice the mortality rate from uterine cancer when compared to non-Hispanic white patients. Overall 5-year survival for endometrial cancer in the U.S. is 81%, with a 5-year survival rate of 62% for Black patients and 84% of white patients. And this disparity is widening over time. This past summer, in 2023, there were some updates on classification of endometrial cancers. How do we think about the different types of endometrial cancer?
The terminology surrounding classification of endometrial cancers is changing. Historically, type 1 and type 2 have been used to describe endometrial cancers. But most recently, with the new FIGO 2023 endometrial cancer staging guidelines, these tumors have been reclassified into, quote, aggressive and, quote, non-aggressive disease, which mostly overlaps with the previous designations of type 1 and type 2. We will use this terminology throughout these episodes.
For completeness' sake, we'll briefly describe EIN, or endometrial intraepithelial neoplasia. EIN is the precursor lesion to endometrial cancer, previously known as complex atypical hyperplasia. Up to 40% of EIN diagnoses, when collected from an endometrial biopsy, are eventually upgraded to a cancer diagnosis.
GOG 167 reevaluated pathology results from patients diagnosed with endometrial cancer precursor lesions at community hospitals. On expert pathology review, 29% of patients with a diagnosis of atypical endometrial hyperplasia made by a community hospital pathologist were upgraded to carcinoma. EIN is associated with unopposed estrogen and can harbor a variety of mutations. It can give rise to endometrial cancer with any of the 4 molecular subtypes. In our next podcast, we'll discuss management of EIN, which often falls to the gyn-oncologist.
You mentioned aggressive and non-aggressive disease. How do we sort cancers into these categories?
About 80% of endometrial carcinomas are non-aggressive. These are grade 1 to 2 with endometrioid histology and can be any molecular subtype. Grade for endometrial cancer is based on the proportion of solid areas. Low-grade cancers have less than 50% solid growth. Nuclear atypia also elevates the grade, should prompt the evaluation for P53, and raises concern for serous carcinoma. The remainder of endometrial cancers are considered aggressive. These include grade 3 endometrioid and non-endometrioid histologies. Grade 3 endometrioid tumors more commonly have p53 mutations than their non-aggressive counterparts. As we'll soon discuss in more detail, this molecular signature negatively impacts prognosis. What about non-endometrioid histologies, Maya?
Serous carcinoma is the second most common type of endometrial cancer, accounting for about 10% of all cases. They have marked nuclear atypia, most are p53 mutated, and a minority of cases are HER2 amplified. Clear cell histology accounts for less than 5% of all endometrial cancer cases. It usually affects older patients, is generally ER negative, and can be any molecular subtype. Mixed carcinomas, unsurprisingly, are any carcinoma with at least two distinct types. They usually represent different clones of the same primary tumor. In undifferentiated or dedifferentiated endometrial cancer, there is no glandular or squamous differentiation. In dedifferentiated endometrial carcinoma, a grade 1 to 2 endometrial cancer is often seen next to the area of undifferentiated carcinoma.
Lastly, carcinosarcoma, previously named malignant mixed Mullerian tumor, represents less than 5% of all endometrial cancer. They were historically classified as uterine sarcomas, but have been reclassified as carcinomas, a group with which they share closer epidemiology, risk factors, and clinical behaviors. Aside from histology, Maya, are there other ways to characterize endometrial cancers?
In addition to type 1 versus type 2, or aggressive versus non-aggressive classification schemes, molecular subtypes have emerged with important prognostic implications. The Cancer Genome Atlas (TCGA) study performed an integrated genomic, transcriptomic, and proteomic analysis of 373 endometrial carcinomas. These included low-grade endometrioid, high-grade endometrioid, and serous carcinomas. TCGA was able to identify 4 major molecular subtypes with significantly differing clinical prognoses.
But how do we determine which molecular subtype each cancer has?
Testing for molecular classification can be completed with 3 immunohistochemistry IHC tests for p53, MSH6, and PMS2, and 1 molecular test for POLE. We'll discuss each molecular subtype in the hierarchical order in which we classify them. The first molecular subtype is POLE ultramutated. POLE stands for DNA polymerase epsilon. These tumors are copy number stable and will have a very high number of somatic mutations in the tumor. They're usually high-grade tumors with deep myometrial invasion and LVSI. However, the good news is, irrespective of grade, POLE tumors have excellent prognosis. If a cancer has a POLE mutation, this is its classification.
The second subtype is mismatch repair deficient, dMMR, or microsatellite instability high MSI-H tumors. They have a low number of copy number alterations but have a high mutational burden due to the abnormal mismatch repair. They are caused by either epigenetic silencing of MLH1 due to hypermethylation, other somatic mutations, or germline mutations such as Lynch syndrome. These tumors have high TMB, often greater than 10 mutations per megabase, which will be important when discussing adjuvant treatment later. They overall have an intermediate prognosis.
The third subtype is p53 mutated. These are also called copy number high or serous-like tumors. These are the most aggressive subtype. They carry a poor prognosis and are responsible for about 70% of endometrial cancer mortality. The mutational profile is similar to that of high-grade serous ovarian carcinoma. Serous carcinomas and carcinosarcomas are almost always p53 mutated, followed by clear cell and grade 3 endometrioid. Grade 1 to 2 endometrioid are rarely p53 mutated. About a quarter of these tumors will also have HER2 amplification.
The last subtype is NSMP, no specific molecular profile. Essentially, all the endometrial cancers that don't meet the above categories are lumped into NSMP. They are copy number low with wild-type p53, have a moderate mutational load, are mostly endometrioid, and are mostly ER/PR positive. These tumors have an intermediate prognosis.
Now, some tumors will have multiple of these mutations, which can be difficult to understand. However, there is an order in which we understand the driving mutation that dictates the subtype. First POLE, then MMR status, then p53 expression. For example, if a tumor has both POLE and a p53 mutation, that tumor would be classified as POLE mutated because the tumor can develop a p53 mutation as a result of the POLE mutation, because that POLE mutation is causing high numbers of somatic mutations. In this case, the p53 mutation is incidental and isn't driving the disease, so the tumor keeps the same good prognosis from being POLE mutated. You can find a corresponding figure in our show notes at our website, readysetgyo.com.
In summary, molecular subtyping is ubiquitously helpful, but can be of particular importance in certain tumors. High-grade endometrial cancers are a clinically, molecularly, and prognostically heterogeneous group for which molecular subtyping is especially important. In high-grade endometrioid, as with other endometrial cancers, POLE portends an improved prognosis, and p53 mutation indicates a poor prognosis. High-grade endometrial cancers that are NSMP, especially when ER negative, have a poor prognosis. Therefore, it is essential to perform molecular subtyping on these tumors due to the significant prognostic changes. Molecular subtyping equips the clinician to understand prognosis and appropriately treat patients based on their risk group. Maya, what are the risk factors for endometrial cancer, and are they different in different molecular groups?
There are very different risk factors between the non-aggressive type 1 tumors and aggressive type 2 tumors. The primary driver for development of type 1 cancer is unopposed estrogen. Unopposed estrogen leads to increased mitotic activity of endometrial cells, resulting in more frequent errors in DNA replication and somatic mutations. Unopposed estrogen can result from obesity, estrogen-producing tumors, diabetes, high-fat diets, chronic anovulation, and of course, exogenous estrogen, among others.
Exogenous estrogen comes in the form of unopposed estrogen therapy and tamoxifen. Tamoxifen is a selective estrogen receptor modulator. In the endometrium, it is an estrogen agonist in the postmenopausal patient, and its effect depends on the dose and time of use. The relative risk for development of endometrial cancer in the setting of tamoxifen use is 6 to 7.5, with the greatest cumulative risk after 5 years of tamoxifen use. However, about 1/3 of endometrial cancers attributed to tamoxifen use develop within 2 years of therapy.
Type 2 aggressive tumors carry a different set of risk factors, including lower BMI, older age at diagnosis, Black race, parity, and personal history of breast cancer. These cancers are not typically estrogen sensitive. About 95% of endometrial cancers are caused by sporadic somatic mutations. However, germline mutations cause endometrial cancer in about 5% of patients. These cancers generally occur about 10 to 20 years before sporadic cancer. The main syndromes to keep in mind are Lynch syndrome and Cowden syndrome. Patients with a first-degree relative with endometrial cancer may also be at higher risk. We'll discuss hereditary cancers in much more detail in a future episode. Sydney, aside from molecular subtype, what else affects prognosis?
Stage is a significant predictor of prognosis. 5-year survival for localized disease is 95%. It drops to 70% with regional spread and is a slim 18% for distant metastases, based on SEER data. Other factors with prognostic value include histologic subtype, grade, myometrial depth of invasion, and LVSI. But before we can stage endometrial cancer, it needs to be diagnosed. What is the role of the gynecologist in diagnosing endometrial cancers?
A lot of endometrial cancer is diagnosed by generalist OBGYNs or primary care providers who perform endometrial biopsy. But practice patterns surrounding diagnostic pathways differ a lot, and sometimes GYN oncologists are involved earlier in that pathway. We won't spend too much time on diagnosis, as it is something covered in other educational resources that are geared towards the OBGYN specialist, but here's a quick overview to contextualize the following 3 episodes. Unfortunately, there's no universal screening for endometrial cancer, but about 75 to 90% of patients with endometrial cancer have abnormal uterine bleeding or postmenopausal bleeding. Physical exam findings are typically normal in the early stage, but sometimes the uterus can become enlarged or fixed in the advanced stage.
Components of initial diagnostic processes generally include some combination of a CBC, imaging, expert pathology review with additional endometrial sampling as indicated, and evaluation for inherited cancer risk. EMB is the most common sampling technique with about a 90% sensitivity. However, biopsy with hysteroscopic guidance and DNC have both improved diagnostic accuracy and are helpful when initial biopsy is inconclusive or suspicion for cancer is high.
Traditionally, guidelines have suggested that an endometrial thickness greater than 4 millimeters in symptomatic patients or greater than 11 millimeters in asymptomatic patients raises concern for endometrial cancer. However, there's increasing data that ultrasound has very poor performance in Black patients and those with aggressive cancers. If any patient has a high risk for uterine cancer or has persistent symptoms, it's imperative to obtain a tissue sample with either an endometrial biopsy or a DNC.
So let's say my friend from residency calls me and says she's diagnosed an endometrial cancer in her clinic. What should she do next?
Well, of course, she should make a referral to her trusty gyn-onc. In the interim, initiation of comorbidity optimization can be very helpful, and we'll talk about this more in a future episode. Preoperative assessment of metastatic disease with imaging is not always required, but it can be important if the patient is a poor surgical candidate, has a high-grade or aggressive disease, or when there are symptoms that suggest distant metastasis or inoperable disease. The most common imaging modality is a CT chest, abdomen, pelvis, but a chest X-ray is also an acceptable first step. Notably, nearly 20% of women believed preoperatively to have early-stage uterine cancer are found to have stage 3 to 4 disease, so imaging really can be of great importance. We mentioned earlier that there have been some updates to uterine cancer classification and staging recently. What are these?
Yes, this summer, in fact. The FIGO 2023 endometrial cancer staging system was revised, and it has some significant changes. The new system is complex and attempts to capture prognostic factors to help physicians make treatment decisions. There's been a lot of debate about this new staging system in the gyn-onc community, which we won't cover here. Stay tuned for next episode when we will review how to adequately stage these cancers and the historical context guiding those decisions.
The major update with the 2023 staging is the incorporation of molecular subtyping, which in some cases may alter the stage of disease. Polymutated and p53 mutated tumors can be downgraded or upgraded with their stage in stage 1 and 2 disease. So in surgical stage 1 or stage 2 disease with an identified polymutation, it's now classified as stage 1A M polymutated. In stage 1 or 2 disease with a p53 mutation with any myometrial invasion, it's now stage 2C M p53 abnormal. The M indicates the molecular subtype. Once a tumor is stage 3, the molecular classification won't change the stage, but it should be recorded as it does have prognostic value. MMR deficient or NSMP status doesn't modify any FIGO stage disease. However, these molecular classifications should also be recorded as they also have prognostic value. So Sydney, have there been any changes to stage 1 disease?
The big update in stage 1 disease is the consideration of histologic subtype, being aggressive versus non-aggressive, addition of categories for stage confined to the endometrium or a polyp, and consideration of the extent of LVSI. This is very different than the 2009 FIGO staging system, which only considered depth of invasion to differentiate between 1A and 1B. Stage 1A3 is a new category which includes low-grade endometrial carcinomas limited to the uterus and ovary.
What about stage 2?
Stage 2 now also captures the misfits from stage 1, instead of exclusively being about cervical stromal involvement. These include substantial LVSI and aggressive subtypes with myometrial invasion. Maya, how have stage 3 and 4 changed?
There aren't major additions to stage 3 disease, but the new system has further separated the categories. Stage 3A has been split into adnexal versus serosal involvement, but one must remember to think about whether the conditions for stage 1A3 are met. Stage 3B2 now describes spread to the pelvic peritoneum. And stage 3C has always described lymph nodes, but it now breaks it down into more specific categories based on micro and macro metastases. We'll discuss this further in later episodes. Stage 4 has added an additional substage for extrapelvic peritoneal metastases, which is now stage 4B. This is a rare occurrence and is different than distant metastases. Positive pelvic washings are not included in the staging system, and neither are the presence of intraluminal tubal floating tumor fragments. It'll be hard for anyone to completely memorize the staging system, so here we've just covered the big updates, and you'll want to keep a copy on hand for when you have to stage patients in clinic.
We really hope you enjoyed today's episode of Ready, Set, GYO. Here are your key takeaways. Not only is uterine cancer the most common gynecologic cancer in the U.S., it's also the cancer in which we're having a really hard time improving outcomes. Both incidence and mortality are increasing.
Risk factors for uterine cancer depend on the subtype. Non-aggressive tumors are related to unopposed estrogen and are often preceded by a diagnosis of EIN, while risk factors for aggressive tumors include age, race, and lower BMI, but not estrogen exposure.
Whereas we used to think about type 1 and type 2 endometrial cancers, with the new guidelines from FIGO, we are now classifying endometrial cancers as, quote, aggressive and, quote, non-aggressive. These mostly overlap with the previous specifications. Non-aggressive endometrial cancers are endometrioid histology, grade 1 to 2, of any molecular subtype, and aggressive is anything not meeting that criteria.
Endometrial cancer prognosis is multifactorial, with age, stage, grade, histologic subtype, depth of invasion, presence of LVSI, tumor size, and location all affecting prognosis. Molecular subtype also greatly impacts prognosis. POLE mutated tumors have an excellent prognosis irrespective of grade. P53 mutated tumors, also known as serous-like tumors, are the most aggressive type that have poor prognosis. And the other subtypes, NSMP and MMR deficient, both have intermediate prognostic significance.
Staging of endometrial cancer has been updated with the new FIGO 2023 staging system. The new staging system incorporates molecular subtype and uses this in the case of stage 1 to 2 POLE mutated and P53 mutated tumors to guide therapy decisions. Histologic subtype, LVSI, presence of peritoneal metastases are some other notable new factors which are included in the staging system. The crux of this new system is that it is an attempt to offer more prognostic value.
Newly diagnosed patients with endometrial cancer should be tested for Lynch syndrome, should have at least a chest x-ray done to evaluate for metastatic disease with more extensive imaging if reason to suspect metastatic disease, and should be assessed for fitness for surgery and goals and priorities for care to help decide treatment pathways. This has been another episode of Ready, Set, GYO, your source for all things gyno.
If you'd like to check out today's show notes, take some practice questions, or explore resources we use to create the podcast, head to readysetgyo.com, the companion website for our podcast. We encourage you to reach out if you have ideas for new episodes, questions or comments about existing episodes, or thoughts of how we can make this podcast even better suited for you. We're excited to continue to learn with you.
To stay up to date on all things Ready, Set, GYO, check out our Instagram and Twitter at ReadySetGYO.
To support us and our production of future episodes, check out our Patreon at ReadySetGYO.
This episode was recorded by Sydney Oesch and Maya Gross.
Our sound editor is Brogan Brown.
Our media and website manager is Sky Jacobson. Sydney and Maya signing off. We'd like to thank Dr. Summer Wallace, faculty at the University of Wisconsin, who reviewed the content of this episode for accuracy and completeness.